Hi, I'm Marie Bellamy. I'm the medical lead for clinical governance at the Hunter New England Local Health District, and I'm also the Director of Medical Services at the Mater Hospital in North Sydney. I feel as though I've been involved in open disclosure forever, having led the development of the first open disclosure standard for the Australian Commission in Safety and Quality for Healthcare in the early 2000s. Since that time, I have seen a definite change in the emphasis within the open disclosure process and requirements. We started focused mainly on a risk management strategy for facilities and practitioners, and over time there's been a much greater emphasis on the needs of the patient, their carers and families. And in recent times, the last piece of the jigsaw puzzle has been paying attention to the needs of the clinicians who get involved in these patient safety incidents. We're working in this video to the definitions and processes as set out in the New South Wales Health Policy and Handbook, although those principles and processes are equally applicable to any state or territory in Australia. We are focusing on skills development for practitioners, but we are also providing some theory as backup and also some challenging cases for reflection. You'll be shown two scenarios of open disclosure conversations. Both of these conversations involve the delivery of the findings of an investigation report to a family member of a patient who has died as a result of a patient safety incident. One of the scenarios, we believe, shows a process that has not been done so well, and the other is closer to the mark to what we would think would be a more acceptable way to conduct that conversation. There'll be a pause after each of the videos for you to reflect on what went well, what didn't go so well, and what should be improved. And we'll have a discussion about that.
Hi, I'm Dr. Riley, and I've organised this meeting today to take you through the outcomes of the investigation report regarding patient Mary Whistler.
My mother.
Your mother. It has highlighted a few system issues that I'd like to take you through today.
No kidding.
If that's all right. Firstly, the drug that was used was a very new drug, as you know, because you brought it in from a commercial pharmacy. Is that correct?
That is correct. What does that mean?
So,
it's a new drug. So what?
It was new, so our staff did not have the adequate time to familiarise themselves with the drug.
Shouldn't they make the time?
They were not given the appropriate amount of time.
Who cares? An old lady dies.
I'm sorry that you feel that way. Also, because Mary's condition was extremely difficult to treat, she had wild swings in glucose levels and many and varied treatment plans that our staff had to keep up to date with. Secondly, the report reveals that the nurse staff had failed to follow policy. The nurses involved should have double-checked the drug before they administered it.
No, really, they should have checked it.
Which they did not.
They did not. Did they get sacked?
Sorry. Just give me a second.
Got a phone call. No problem at all. Take your time. How bloody rude.
Apologies, I just had another patient. Sorry.
And I want to know about my mother's mental decline after the overdose.
Right.
And I think that it contributed to her death also.
Okay, so we had an independent endocrinologist have a look at the issue.
Oh, did you?
Yes, and she concluded that there was no significant link between the overdose of insulin and to your mother's mental decline.
Not significantly.
Not significantly. And she felt that it was actually the recurrent low blood sugar levels over that 12-month period that was the cause.
Oh, did she? Right.
Yes.
Well, I'd like to see how big the link was. I would like a copy of your report there.
I don't believe that it will be useful for you, as there is a lot of information in there and it is incredibly hard to interpret. So I'm here to do that for you.
You've been able to interpret it. I have a right to see that report. I should have been invited to be involved in it. I want to see the report, or I will apply for one through GEPA.
Okay.
It's up to you. Are you trying to hide something from me?
No, Jessica, we're not trying to hide anything from you. Here's the report.
Thank you.
There's another finding in there.
Oh, surprise.
About the use of abbreviations that didn't follow hospital policy. In this case, the medication was written out as 15U, U being shorthand for units. That was misinterpreted as 150 units.
Written by whom?
The registrar.
A doctor. A doctor did that.
Correct.
Where's the doctor today? Have they been sacked? Any consequences?
No, the doctor involved has not been sacked. I'm here representing all the medical staff who were involved in this incident. There are recommended changes you will see in the report to ensure this doesn't happen again.
Atrociously bad behaviour on your part. Medical professionals who are supposed to be responsible.
I'm sorry that you feel that this is atrocious behaviour.
I'm not sorry at all. But I'm taking it further, don't worry about that. I'm not happy at all. You haven't answered any of my questions. You haven't made me feel any happier about anything. So I'm taking this matter further. Trust me, I am taking it further.
Okay, so any more questions?
No. Nothing that I want to raise with you. But I'm taking it further, don't worry about that.
Okay. I'm sorry you feel that we haven't provided enough information, and it is your prerogative to take this matter further. We'd be happy to provide those contact details for the relevant bodies.
It's nice of you to do something for me finally.
Thank you for your time today.
Thanks for nothing.
You've just watched a discussion between the doctor and the patient's daughter that occurred some weeks after the patient safety incident and after the investigation has been finalised, and the point of the conversation is to discuss what was found. I'd like to highlight some of the issues that I identified. I guess to begin with, one has to say at least there was a conversation occurring, although you could hardly consider it satisfactory from the perspective of the patient's daughter. The doctor did introduce herself and sit down, maintained good eye contact during the conversation, but there were some major issues that I think needed to be improved upon. One of the key omissions was the opportunity for the patient's daughter to give any input into the discussion and to ask questions. In fact, it really wasn't a conversation, it was more of an information dump. I have this report and information for you, and you're going to listen. In fact, the doctor uses the words, "I have organised this meeting to take you through the report." So there's no opportunity intended to actually hear what the other party has to say or what their concerns are. It's a trap that we often see staff members fall into. They have lots of facts to convey to the patient or their family, but unless you listen to their concerns, you will find very often it's not necessarily the information that they are seeking, and it doesn't address their concerns. We hope that this will happen less often now that we are including the family members and the patients in the interviewing process for these investigations from the outset, improving the communication and giving us the ability to know what their concerns are from an early point in time. The doctor also allowed interruptions. She hadn't turned her mobile telephone off and created a sense that she was in a rush and really not fully there in the moment with the patient's daughter, which caused some degree of agitation. It's important that we create the impression with these conversations that they are a priority, that they matter to us, and that the people with whom we're conversing matter to us. There was no opportunity for Mary's daughter to express her emotions, and certainly there was no sign of an apology. In fact, one got the sense that Mary was somehow to blame for this whole mess. Those wildly swinging blood sugar levels, constantly changing treatment plans, and the family bringing in a new insulin from the commercial pharmacy into the ward were all portrayed as creating the problem. The reluctance to provide full information also created problems for the doctor. Given that the purpose of this meeting was to discuss the findings of an investigation and to go through a report, it would have seemed quite reasonable to provide the patient's daughter with a copy of some of that information for her perusal, but instead came across as a cover-up of which the patient's daughter was quite suspicious. There was no information given about how to follow up, who to contact, and of course by this point in time the daughter was so incensed that she had clearly made a decision that she was going to take the matter further with other authorities.
Hi, Jessica.
Yeah.
I'm Dr. Emma O'Reilly. How are you?
I'm fine, thank you.
Thank you so much for coming in today. Is there anything else I can get you? Coffee, tea, water?
I'm fine, thanks.
Okay, great. Firstly, Jessica, I would like to apologise personally, as well on behalf of the hospital, for the incorrect dose of insulin given to your mother, Mary. And I know that because of this, Mary was taken to the high dependency unit, which I can imagine was incredibly distressing for you and the family. And for that, I am very sorry. I also know that Mary recently passed away, and I am very sorry for your loss. Please let me know if you would like to take a break.
I'm fine, thank you.
Okay. So, may we start today, Jessica, by asking what you know or understand about the events so far?
I don't understand anything.
Okay.
It's been terrible. Terrible. I arrived here 7 weeks ago to visit my mother to find out that she's been transferred overnight to that high dependency unit. Nobody phones me. I would have come in immediately so that I could be a source of comfort for her. And then I'm told that she's been transferred there because someone on your staff, a nurse, a couple of nurses, administered 10 times the recommended dose of insulin to her, and they'd found her unresponsive. I don't understand. I don't understand that. I don't know anything about that. No one's been in touch with me. Someone the day after from Patient Safety or whatever it's called told me there was going to be an investigation, that I would be contacted to be interviewed, and then I'd be called in to discuss the findings of the investigation. And I've heard nothing from anybody in 7 weeks.
Okay.
And Mum died.
Okay.
So I had to file a formal complaint.
Okay. I can see that that would be incredibly infuriating and upsetting. And for that, I am sorry. And I am very sorry that there was a breakdown of communication. That shouldn't have happened. You should always feel like there's a line of communication between us. I will talk directly to the coordinators and pass on that information to ensure that doesn't happen for future families. For any other contact, I will be your person. And do you have my contact details, Jessica?
I do.
Okay, great. Is there anything else you would like to bring up today?
Yeah, of course there's other stuff. What were the consequences for the nurses who made that bloody mistake? Were they sacked?
The people involved will not be sacked. The report shows there were, however, some system issues.
I'm kidding.
And I'd like to take you through that today.
Oh, please do.
Firstly, staff were unfamiliar with the drug and they weren't aware that the high dosage was unusual, as we didn't stock the drug in the hospital. Secondly, the junior nursing staff did have questions about that high dosage, but she didn't feel that she was senior enough to speak up about it. And lastly, 2 policies were not followed by staff members. This was to double check the drugs before administration and to avoid using abbreviation when prescribing drugs. And I have to let you know, Jessica, that I was personally implicated in this, as when I was in consultation with the specialist, I wrote down 15U, that was shorthand for units, and this was interpreted by the registrar as 150 units. This was, of course, a transcribing error, and I take personal responsibility as well as the hospital taking responsibility for this error. So, in light of these issues, we've come up with some recommended changes to make sure this doesn't happen again. These changes are here in the report, which I'd love to give you a copy of. So there are a number of changes in there, but we have a focus on re-educating staff and particularly about the use of abbreviations when prescribing medications. If you want to take that home and read it at your convenience and have time to digest it, and then we'd love to know your thoughts on it.
Oh yeah, I'll be looking at that.
Is there anything else, Jessica, you'd like to speak about today?
Yeah, okay, so I want to know what you know. Do you know if that overdose was responsible for my mother's rapid decline and then ultimate death? Because it looks that way to me.
I can see why you would be concerned. We had an independent endocrinologist have a look at the issue and see its possible impact on Mary. And from her assessment, she found that there was no significant link between the overdose of insulin and the cognitive decline, not from her findings. She believes that the recurrent blood sugar levels, the low blood sugar levels over that 12-month period would have been the cause of the cognitive decline. I can give you a copy of the endocrinologist's report if you would like.
Yes, I would, thank you.
Okay, great. And I can set up a meeting with her so that you can discuss the findings.
Okay, that'd be great.
Okay,
Thank
lovely.
you.
And of course that will come at the cost of the hospital, not you.
Thank you.
Great. Anything further that you would like to talk about?
I think I've got enough to get on with. I need to have some time to look at this and seek another opinion.
Of course, take all the time you need. So just to confirm where we go from here, I will send you a copy of the endocrinologist's report. I will set up an appointment with the doctor at your convenience, and I will also touch base with you in, say, 4 weeks or so to answer any questions or concerns. Does that sound okay?
Yes, thank you. That sounds much more satisfactory than what I've been getting.
I'm incredibly sorry, Jessica. And if you have any other thoughts or questions, please don't hesitate to contact me. I'm here to help. Thank you for coming in today.
Yeah, sure. Thanks.
Okay. Thank you.
So the error was the same, but the way in which this conversation was conducted was very different. It started with a sincere apology for what had happened, and it also acknowledged the daughter's suffering and loss. The daughter's understanding of the incident was sought, and known facts were then shared. Ample opportunity was provided for questions to be asked, and time was allowed for the expression of emotion. The doctor didn't block access to the report. It was provided willingly and openly, and the daughter's feedback was sought. The doctor acknowledged her own potential contribution to the incident overdose. She also spoke of how the organisation had learned from the incident and what changes would be put in place by the organisation to try to prevent a recurrence of the same type of incident again. A clear follow-up plan was established, with the doctor nominating herself as the contact point for future questions or concerns that the patient's daughter might have. I think we should note that ideally this should not have been the first conversation in the open disclosure process. That clinician disclosure conversation should occur within the first 24 hours after a patient safety incident, and on this occasion it doesn't seem to have happened. There was discussion about the daughter being involved in the investigation process, but contact was lost, and that clearly did not occur. It's important to remember that open disclosure is not just about the investigation report. It starts well before that. Incidents need to be assessed early for risk and to determine the type of investigation that's needed, and that provides multiple opportunities for meaningful exchange of information along the way, but starting very soon after the event has occurred.